Hi, I'm David Crow. Thank you for tuning in to episode 201 of my weekly radio show, The Infectious Myth. Email me at david.crow@theinfectiousmyth.com. That's Crow with an E. Join the discussion and like us at facebook.com/theinfectiousmyth. Follow us on Twitter and Instagram at InfectiousMyth. Listen Tuesdays at 2 p.m. U.S. Eastern Time on prn.fm or subscribe to the podcast on iTunes or other programs. You can listen to any of the last 5 episodes over the phone by dialing the U.S. number 701-719-0990 and following the instructions. Just remember that you will be responsible for any long-distance charges. I don't know that you're a listener until I hear from you. Send me a message letting me know how you stay in touch with the show and what you like about it. If you include your mailing address, I will send you a little thank you gift, which will be one of the bookmarks I make by hand using my own photographs. If you'd like to sponsor this show, please contact me. Or you can make a one-time donation via PayPal using the email david.crow@theinfectiousmyth.com, or make monthly donations at patreon.com/infectiousmyth. We appreciate all our listeners, but if you want this show to continue to grow and improve, consider paying a small amount for the information that you are gleaning, for the support you get for some non-mainstream ideas and the challenges to others. I appreciate you commenting and suggesting guests. I appreciate your financial support as well. Thanks for listening and for recommending this show to your friends. And now to our interview. This week it's very important, especially in this month of Movember, which is designed to motivate you to run to your doctor to get your PSA checked. Well, what does the test's inventor say? Richard, or Dick Ablin, is a professor, Department of Pathology, University of Arizona College of Medicine, Arizona Cancer Center, and Bio5 Institute, and President, Robert Benjamin Ablin Foundation for Cancer Research. He received a PhD in microbiology from SUNY Buffalo in 1967 and was a postdoc in immunology. He received the first award for scientific excellence by the Hakon-Rakte Foundation for Advanced Cancer Studies and was a nominee for the Lasker Award in 1997. He is specialized in cryosurgery and cryoimmunotherapy for cancer treatment. In 1970, he discovered PSA, the Prostate Specific Antigen, but in 2010, he wrote a widely read op-ed in the New York Times entitled The Great Prostate Mistake, and in 2014, published a book titled The Great Prostate Hoax, subtitled How Big Medicine Hijacked the PSA Test and Caused a Public Health Disaster. This might be a little bit surprising to you, dear listener, and that's why I'm interviewing Dr. Ablin today. We will discover why the discoverer of PSA doesn't think it should be used, at least not in the way you probably know it's being used. Maybe this interview will change your attitude to Movember when we're taping this. Welcome to the show, Dr. Ablin.
Oh, thank you so much, David. I really appreciate this opportunity to talk to your audience, and hopefully some of the things that we'll discuss will be of benefit to men and their families in understanding things that perhaps have just not been clear.
I think it will be. Let's go back to 1970. You discovered the prostate-specific antigen. What were you looking for, and what did you find in this antigen?
Oh, so to try to make this as succinct as possible, I was working with 2 urologists in the mid-60s, and what we were looking at was different ways to treat prostate cancer. And one of the things that we observed was that through a series of experiments in animals, rats, monkeys, dogs, and larger animals, that when the prostate was frozen, that is, we designed with the technical people that we had probe, which was about the size of the urethra, and liquid nitrogen was passed through the probe up into contact either through the urethra or directly onto the prostate when the animals were operated on and opened up. That the freezing of the prostate created an immune response, and that is that if we froze the prostate, for example, in a monkey, the animal developed what we call antibodies, and everybody's heard of these.
Right.
More commonly in terms of when you have a vaccine for tetanus immunizations in children, to develop antibodies to protect yourself. And then more recently, of course, they talk about the flu vaccine, pneumonia vaccines. The idea being here is that when a foreign substance, protein, is injected into an individual, they produce antibodies, and these antibodies hopefully will combat the virus or the bacteria
Right.
when an individual comes in contact with them. So similar to vaccination, we found that when you froze the prostate, you stimulated an immune response, both in terms of serum antibodies that are found in the blood,
Mm-hmm.
and also cellular that are conveyed by cells in the body. Some of you have heard of lymphocytes and
Right.
macrophages and other types of natural killer cells and types of cells that constitute, what we call, cellular immunity.
Mm-hmm.
And so what we found was that when we immunized, in this case, the immunogen was the liquid nitrogen. And when we froze the prostate, we had an instrument that the liquid nitrogen flowed through.
Right.
And when it came in contact with a certain section of this probe, we call a cryoprobe,
Right.
that didn't have the insulation, it then froze the prostate. So
Okay.
moving along, we discovered this immune response, and based upon a series of studies over a few years in animals, we then applied this in the treatment of prostate cancer in humans, in men. And
Mm-hmm.
what we found was in men who had cancer of the prostate, which is about the size of a chestnut, we found that these men had an immune response, and in some cases, these men had metastasis, that's cancer,
Mm-hmm.
that had spread beyond from the prostate to other parts of the body. What we found was that these men had what we call the remission of the metastasis. That is, that the metastasis after the freezing disappeared. They went into what we call regression. They either completely disappeared or they regressed to the point, that they weren't visible. For example, some men had metastasis in the lungs, and
Right.
when they took an X-ray, you could see the metastasis. And then following treatment with the cryosurgery, the cancer disappeared. At least it wasn't visible by the method of detection. And so,
Can I try to read this back to you just to make sure that I've got it right?
yeah,
So you start with a man who not only has cancer in his prostate, but the cancer is metastasized to other parts of their body, and that when you freeze the prostate where it's supposed to be, and you generate these antibodies as part of the reaction to the freezing, then that caused the metastasized cancers that were in other parts of the body to disappear.
yes, that's correct.
Okay.
But we must make it clear that this is a limited study, and unfortunately not in every patient, that was treated had this reaction. There initially was a group of about 6 men who had this reaction, which because of its rather remarkable effect, it drew a lot of attention from the media, from the press. And one of the questions that came out of this was, why are you getting, antibodies, and why are these antibodies, having this tumoricidal effect where they're destroying, distant metastases? So the question here, towards answering in a long-winded way, how I got started here in discovering PSA, which is the acronym for Prostate Specific Antigen, is that, so there was a lot of question, what's happening here? Why are you getting the production of antibodies? The answer was, I thought, was somewhat related to the fact that as general phenomenon, in immunology and immunization, that there's an antigen that was released from the prostate following freezing, or there was a normal protein that was altered by the freezing process that was stimulating this immune response. So in the process of trying to answer this question, I began to collect tissues from normal prostates, from men who had what we call benign prostatic hypertrophy, which is an enlargement of the prostate, which most men start to acquire about the age of 40, where the prostate gets large. And if you can visualize a garden hose as the urethra that goes through the prostate, when the prostate would get larger, it would compress on the garden hose, and it would result in the necessity for urinating, getting up at night and urinating, more than once, twice, 3 times, because of the enlargement of the prostate pressing on the urethra. And then, of course, there's unfortunately the development of cancer of the prostate. And I collected specimens of normal tissue from people who perhaps died from other diseases, and of course had permission from the families to obtain samples of their prostates, which were normal, and also samples from men who underwent surgery to correct the benign problem that they were having that was causing them to have difficulty urinating, and then of course from men who had cancer of the prostate. And so I took these tissues and I began a series of studies, biochemical, immunological, and a variety of different studies to study the components, proteins of these 3 tissues. So what I found was that each of these, the normal, benign, and malignant prostate, had a series of proteins, and that these proteins were specific for the prostate. They weren't found in the spleen, the kidney, or other parts of the body, and so called them prostate specific antigens. We call them tissue specific,
right,
because they were specific for the prostate. So my search was to try to figure out how this was happening. And so one of the ideas was that I was looking for a cancer-specific protein or antigen. That is, that the antigen would not be found in the normal prostate, the benign prostate, but only be found in the malignant prostate.
Right.
Much to my disappointment, while I discovered these prostate, specific antigens, unfortunately, while I discovered prostate-specific antigens, this antigen was present in the normal, the benign, and the malignant prostate.
Is it true that the PSA levels tend to be higher when the prostate is not happy, whether it's benign or cancerous? So if you take a normal prostate versus one that's having some kind of problems, whether it's the normal, benign, enlargement that occurs with age, or whether it's cancer, that you would have a higher PSA level in general?
Right. So what then happened is that my quest, for a tumor or cancer-specific antigen, I wasn't successful. I did a series of experiments in which I took blood serum from patients with prostate cancer before and after they had this surgery. In other words, conventional surgery is referred to as a prostatectomy.
Right, the removal of the prostate entirely.
The removal of the prostate is one means of treating diseases of the prostate. So what I did was I took some patients and I took their blood using an immunological procedure. I analyzed the serum components from patients who had prostate cancer for any treatment, and in particular cryosurgery. And then I took serum from patients after treatment, cryosurgery, and I compared the levels of these, and I could find that patients before surgery had a higher level of this protein than they did following surgery, which suggested that and confirmed, that the origin of this protein was from the prostate.
Right.
And then when the prostate, was treated, there was a lower level of the protein. But the difficulty was, at that time, was that I was trying to identify a cancer-specific or a tumor-specific protein.
Right.
And I wasn't successful. What I saw, I said to myself, well, this might be useful for what's called prognosis. That is that when you have a patient that's diagnosed with prostate cancer and you treat the patient, that you could follow the patients after treatment by measuring the level of PSA. What this was to see was, the question was, what did this protein, this PSA, what could the possible use of this protein be? The possible use of the level of this protein in the blood before surgery versus after surgery was that because of the fact that the protein was specific for the prostate, when you removed or destroyed the prostate and you measured the level of PSA after treatment, the level was less.
Right.
So what happened here was that I observed this, but it didn't seem that time to me to be, it wasn't what I was looking for.
Right.
And so I basically left, having discovered PSA and noticing that there was a difference between serum or blood, between preoperative and postoperative treatments. I didn't, at that time, it wasn't what I was looking for, and so I left it.
Right.
Now, what happened is, to answer your question, that PSA could be a prognostic marker for the successfulness of the treatment of prostate cancer. So
Right.
that when a man was treated, you measured his level of PSA prior to treatment, and then after treatment, you measured the level of PSA. And the PSA theoretically should be gone because the prostate is gone.
Right.
And so therefore, what you could do is you could use a test to follow men following treatment to see how successful the treatment was.
It was approved in 1986 for this.
You're right. So what happened was I wasn't taken, either fortunately or unfortunately, with this observation. I identified this protein. It wasn't cancer specific. It wasn't what I was looking for, and I left it.
Mm-hmm.
Okay, now, 9 years later, some other people came along and they saw what I had found 9 years ago, and they became interested. They took this information and they then put it together in a test, which I had done 9 years earlier, but I did nothing with it because of what I explained. It wasn't what I was looking for. And so
Right.
what they then did is they then presented this information to the Food and Drug Administration,
Mm-hmm.
and the FDA approved the test that what you would do is that if you looked at an asymptomatic man and you found that there was an elevated level of PSA, well, if he was diagnosed with prostate cancer, then they treated the man and they saw following treatment his level went down.
Right.
Okay, so that was what was called a prognostic test. The first use that was approved by the FDA in 1986 was when a man was treated for prostate cancer, you would follow that man by taking blood samples and looking at the level of PSA. If the level of PSA went down, that coincided with successful treatment.
Right.
In 1994, the medical establishment and the urological community got carried away with the idea of this PSA test, and what they did was they presented it to the FDA, and by a big mistake, the FDA approved this test for the diagnosis of prostate cancer. They said that if you had an asymptomatic man, a man who had no symptoms of prostate cancer, and you found an elevated level of PSA, that indicated that the man had prostate cancer.
Yes.
And that in combination with a digital rectal exam,
Mm-hmm.
that man had prostate cancer. He should have a biopsy, and if the biopsy was positive for cancer, he should be treated for prostate cancer.
Mm-hmm.
Therein lied a tremendous problem in the medical profession. The difficulty is that, if you remember, a few minutes back I was explaining that PSA was prostate specific.
Right.
It was specific for the prostate, but it was not specific for cancer.
Right.
It was found in the normal and the benign prostate, and that's the reason why that I didn't continue with my work in that avenue, because of the fact that while you could show that there was a decrease in PSA following treatment, PSA could not be used as a diagnostic tool to detect prostate cancer, because while it was prostate specific, it wasn't cancer specific. We now need to understand there's three diseases of the prostate. There's prostatitis, which in many cases is an infection.
Mm-hmm.
And in some cases, oddly enough, it may be related to certain types of food or alcohol irritants. Anything that irritates the prostate can cause an elevation in PSA. For example, if you're a truck driver driving from Calgary down to Los Angeles, and you then had a PSA test from bouncing up and down in the cabin, which would irritate the prostate, you could have an elevation of PSA.
Right.
If you had, the night before you had a PSA test, you were involved in some heavy sexual activity, which obviously would involve the prostate,
Right.
you could elevate the level of PSA. If you were involved in homosexual activity rather than heterosexual activity, you could also elevate the level of PSA.
Oh, really?
So the difficulty here is that prostatitis could cause an elevation in PSA. If you had an enlarged prostate, you could have an elevation in PSA. So the difficulty and the calamity of using the PSA test my book, The Great Prostate Hoax, is, I don't know if it's an expose, but it's an explanation as to the downfall in the PSA test is that because PSA can be elevated not only in cancer, but elevated in prostatitis and elevated in BPH, it's not cancer specific. So therefore, if a man has an elevated level of PSA, it doesn't necessarily mean that a man has prostate cancer.
But they also do the digital rectal exam, so...
Right. The digital rectal exam, the reason why there was so much excitement when the PSA test came out was because the incidence of prostate cancer by the digital rectal exam, there were so many false positives, is that they were excited by the fact that if you had a non-invasive test, a blood test, that could detect prostate cancer, this was a boon in the practice of urology. Between 2009, just to give you some data, and 2012, or 3 years, there was more than 3 million men who had a needle biopsy of the prostate.
Uh-huh.
Okay? Of those 3 million men, 300,000 of those men needlessly had a radical prostatectomy. In other words, the trouble with the digital rectal exam is that it's a very poor test.
Mm-hmm.
And what happens is that when you have a biopsy and you look at the prostate under a microscope, it's very, very difficult to distinguish cancer in many cases from the BPH and prostatitis, although it is definitive. But the difficulty is that, it's often been said that, by some pathologists, that if you look hard enough, you'll find prostate cancer. There's various levels or degrees of prostate cancer. And so the difficulty with the digital rectal exam is that there are a significant number of false positives.
Right.
As I said, there were, on biopsy, in that one period of time that, I quoted you, there were 300,000 men in that just one data set who ended up with false positives. They didn't need to have their prostate removed.
Is it true that most elderly men who die of something other than prostate cancer have some prostate cancer cells in their body?
Yeah. So here, let me then go into that quickly because you brought it up. But then let me return to the all-important reason of the problem with the PSA test. So what we find is, if you look at a spectrum of men from the ages of 20, say through 90 years of age, and as you just said, prostate cancer is an age-related disease.
Mm-hmm.
If we all live long enough, we'll all develop prostate cancer.
Mm-hmm.
But the difficulty is so that if we look at a population of men, say between the age of 60 and 70.
Right.
So if we go into downtown Calgary this evening, and we select a group of 100 men, and we pay them a fee, and we say to them, we make an advertisement, and we're asking for men between the ages of 60 and 70 to report to such and such a clinic or such and such a hospital on a given date, and we will pay them X number of dollars for a biopsy. What we will find is that in that group of men between 60 and 70, close to 70% of those men will have prostate cancer. But what it'll be what's called histological prostate cancer. There's basically two types in a broad categorization, there's what we call clinical prostate cancer and histological prostate cancer.
Mm-hmm.
The majority of men, based upon autopsy studies, will have what's called histological or latent prostate cancer. It will be a prostate cancer that never would have expressed itself clinically. It would never have caused any symptoms in the patient. The other group of men have clinical prostate cancer. That's prostate cancer that will affect men clinically. And so the difficulty is, because prostate cancer is an age-related disease, when you do a PSA test in elderly men, because of the cancer being age-related, depending upon the age of the man in which the PSA test is done, they will have prostate cancer. But it will be histological prostate cancer or asymptomatic prostate cancer or latent prostate cancer. It'll be prostate cancer that would have never bothered them clinically.
Right. So what you're really saying is that although there's 3 tests and each test could eliminate some men from further examination, all 3 of them have major flaws which will result in overall a large overdiagnosis rate.
No, wait. You said 3 tests. I missed that.
Okay, so we have the PSA test. So men will have a PSA test. If they have an elevated PSA, they'll go for a digital rectal exam, which is...
No. It's not done that. Well, usually what happens is when a man comes to his urologist, the first thing the urologist will do is a DRE.
Oh, okay. That gets done
He'll
first.
put his finger in the rectum and feel for abnormalities of the prostate.
Mm-hmm.
Now, the relative effectiveness of that test is related to the education of that urologist's finger. In other words, if that urologist has felt thousands and thousands of prostates, he's very adept at discovering an abnormality of the prostate. But if he's only a novice, what may not be anything, he may feel, okay, the best way I can describe this is if you hold your hand and you feel, you hold your hand between your thumb and your index finger, if you feel the part between your thumb and the index finger, the middle part, that squishy part, that's what BPH feels like.
Okay.
Okay. If you feel the hard part of the knuckle there on your thumb,
Right.
where it's very hard, that's what prostate cancer feels like. So there's a degree when you do a digital rectal exam of what you're feeling. Okay, so now the urologist does a digital rectal exam, and then first of all, what he'll do is he should do the digital rectal exam before he draws any blood for a PSA test.
Right.
Because if you remember, the slightest agitation or aggravation of the prostate can cause a slight elevation in PSA.
Right.
So it's important when a man has a digital rectal exam that he has it before blood is drawn for a PSA test.
Right.
Okay. So if a man has a suspicious DRE and he then has an elevated level of PSA, and in the beginning it was said that if a man had a level of PSA of greater than 4, for example, when we do cholesterol and triglycerides, the chemistries, we have certain levels which are normal and abnormal. So originally it was said that if a man had a PSA that was greater than 4, that there was a strong possibility that he might have prostate cancer, and that he should be followed up with a biopsy. Are you with me?
I'm with you. Yeah.
Okay. But the difficulty is the digital rectal exam is questionable relative to the education of how many times the man has done a DRE, and the PSA test is suspect, which I'll go back to my explanation, because of the fundamental cruxes that the test has. And so if a man has a slightly elevated level of PSA, he may not have prostate cancer because, as I was trying to explain, and then I go back and finish this here, PSA is not cancer specific. Okay.
Right.
The next thing is there's no level of PSA that's diagnostic for prostate cancer.
Right.
A perfectly good example is a man can have a PSA of 0.5 and have cancer.
Right.
But he can also have a PSA of 11 and not have cancer.
Right.
Also, PSA can't distinguish an indolent, that's a non-aggressive, histologically present cancer from an aggressive cancer. That's a cancer that has the potential to metastasize. And fourth, prostate cancer is an age-related disease. So that if a man has a biopsy in the age in which, as I explained to you, say between 60 and 70% of men will have some cancer, but it's histological.
Right.
So therefore, it's a serendipitous observation. It's not because of, he doesn't have prostate cancer, he has an elevated level of PSA because of his age.
And some cells that maybe many years from now could cause cancer.
Right. So a well-known pathologist, I'm quoting from a quote that I had in a paper, he said, you know, when I presented these different observations to him and other people presented, you know, when I'm telling you about why there's these pitfalls, you know, to quote him, he says, we were afraid to say exactly what we thought for fear of seeming too crazy. It was easy to get financing to study the benefits of screening, but a study that looked at harms was too far out of the culture. In other words, people were getting money for research, for clinical studies, for screening.
And the aim was to make lots of money by getting the screening test approved. So
well, no, the screening test was approved. Okay, so remember, in '86, the test was approved for prognosis.
Right.
In '94, it was approved for diagnosis. And so right after '94, the tsunami of screening, even though it was not approved by the FDA, became phenomenal because of the fact of the money that was associated with a biopsy and a radical prostatectomy.
Right.
And there was, as you remember, as you read in my book, there was a firm, an advertising firm, that was hired to, you know, there's Prostate Cancer Awareness Month, September, and week in June. And in the early days, as cited in my book with the appropriate reference, is one of the pharmaceutical companies that was manufacturing a PSA test, even though it wasn't yet approved for screening, hired an advertising firm to advertise the fears of not being screened and having prostate cancer detected and treated. So what it was, as explained in certain parts of my book, it was a business.
Yes. I mean, you explained quite well how there was tremendous pressure on the FDA to get the test approved, but that was only the first step, because secondly, you've got to persuade urologists to use it, and you have to persuade the average man that he needs to go get his PSA tested.
Yeah, but the way the average urologist, well, you know, we got off here, but we should go back. But to answer this question is, the way the average urologist was pressured into doing a PSA test was that he was sued. In other words, if there's a famous case, and I can email you the short article that appeared in the Journal of the American Medical Association. It's called the Merenstein case, where a resident at Johns Hopkins saw a patient and did not recommend a PSA test for the patient because some urologists in the early days were aware of the pitfalls of the PSA test, and the man, the urologist didn't give him a PSA test. The man subsequently went on to another urologist, got a PSA test, had cancer detected, and then turned around and sued the residents. So the reason why you gave reasons, why people had to want to have screening is because there was the fear of prostate cancer. For a number of years, very high-profile celebrities and sports figures in our country, every year, Rudy Giuliani used to. They advertised in the New York Post. Get screened. Get tested. Get screened. Get cured. So the mantra was put forth that if you had a PSA test and you had prostatic cancer, the test detected the cancer, and then you got treated and you were cured. It didn't talk about up to 60% of men who got a radical prostatectomy became incontinent.
Yes.
It didn't talk about the fact that up to 30% of men who had a radical prostatectomy became impotent. They couldn't get an erection. They couldn't have sexual intercourse.
Right.
Now, obviously, as centers of excellence, these numbers are much lower. But the way this was instilled in the layman was by, as I said at the beginning, our country is a celebrity-starved society. And when baseball players, football players, other sports figures, Arnold Palmer, started to say, who had prostate cancer, get screened, get treated, get cured, that put the fear in the average man, the layman. And when urologists were confronted with cases where if they didn't recommend a PSA test and the patient subsequently developed prostate cancer, they were sued. I've served, for example, on about a dozen cases as an expert witness on the part of the defendant.
Right.
Because the plaintiff, who was treated by the urologist, who didn't give the patient a PSA test or didn't give him a PSA test in a timely enough manner, was sued by the family because either the patient, the father, the uncle, the grandfather died from prostate cancer or developed metastatic disease. And so what I'm trying to illustrate here is that there are a number. Our subject is I guess, in part to the majority, the PSA test. So what I'm trying to illustrate for you is that, which I wanted to bring out a few minutes ago, but let me do it now, is that there's two uses for the PSA test. The first use is for which it was originally approved by the FDA in 1986, and that was for following a man after treatment for prostate cancer in terms of the possibility of its reoccurrence. And the idea there was because PSA is specific for the prostate, not cancer specific, that if the PSA rose following treatment, it suggested that cancer was still present or was present in other parts of the body. And that's the use that it was originally approved for by the FDA. And that use is nationally and internationally accepted. And I don't criticize that use. What I criticize is the deadly decision by the FDA in 1994 to approve the PSA test for screening. And that is taking asymptomatic men who have no evidence of any prostatic disease, and giving them a PSA test. And then based upon the level of the PSA, going on and doing a biopsy and then treating them for prostate cancer. And the result is that many men, young men in their 50s and their 60s, their quality of life is destroyed.
Right.
Sex is not everything, but their family, their wife, in many cases, is dismayed that her husband is no longer a normal man.
Yes. Well, I think both incontinence and impotence have a huge impact on a man's feeling of masculinity. And as you say, it also obviously affects the wife, both in her inability to have sex with her husband, and also she has to deal with a man who needs to wear diapers in many cases.
So when you walk into, when for example, I don't know if you have what's called Costco.
We do.
In Calgary, it's a huge, okay. So you walk into Costco here in Tucson, and a whole wall, when you walk in, if you look to the left, the whole wall is filled with Depends.
Right.
Depends are diapers.
Adult diapers, yes.
Okay. And, well, people as they get older, women, as they get older that don't have any disease, or men that don't have a prostate problem, may have other reasons, don't have prostate cancer, may have other reasons, but Depends, Kimberly Clark, they sponsor what are called prostate cancer support groups throughout the United States. In fact, I've spoken at several of them. I don't know if they have them in Canada.
I'm sure they do.
But the whole idea here is, I'm sorry, I'm a pessimist. The whole idea here is the reason why they support PSA screening is because PSA screening, that's where the urologists get their patients, where they make their money.
Right. Dr. Ablin, we're running out of time. I would like to maybe address something a little bit more positive. Is there has been some trend towards recommending against PSA screening. I think there's an organization called the U.S. Preventive Services Task Force.
Okay, so let me talk about the United States Preventive Services Task Force.
Mm-hmm.
So in 2011, they evaluated the data, and they have a classification scheme, A, B, C, D, and they classified the PSA test, they gave it a D.
Right.
Meaning that the PSA test, that the risks outweigh the benefits. All right?
Okay, yeah.
And that, so the urologists got together in a lobby in Washington and other parts and protested that the United States Preventive Services Task Force group made a bad decision, and that on their task force they didn't have a urologist.
Right.
And because they didn't have a urologist, they didn't get the true picture of what the positive effects of and benefits of PSA screening are. So recently, in 2017, they convened again, and they came out with a ruling earlier this year, and they changed the classification from a D to a C, meaning that a man should discuss, have informed decision-making with his urologist with regard to whether or not to have a PSA test.
Well, I think if more men read your book, or at least
No,
your...
wait, I don't mean to interrupt you, but because of the time, let me explain something critical to you. Okay, so what the FDA said to do is that what you should do is you should sit down with your urologist, and your urologist or your primary care physician will discuss the benefits and the risks of a PSA test.
Right.
Now, the difficulty with that is is that every urologist and every primary care physician, there's no commonality among these physicians. In other words, one urologist may tell a patient one thing and another tell another, and there's been surveys that have been done, and the majority in these cases have shown that in many cases, and I can give you some statistics, I tried to stay away from statistics for your audience, but in many cases, the urologists don't tell them about the risks. They only tell them about the benefits.
Yeah, I think I understand that dynamic. That if you're a man and you're told that you have a prostate cancer, or you're a woman and you're told you have a breast cancer, you're not going to ask, is this a cancer that's going to grow, and what's the consequences of having it treated? How's my life going to be afterwards? As soon as you hear the word cancer, your next thought is, how do we get it out?
No, but wait, before that, what we're missing is these are people that don't know they have cancer. Mm-hmm. These are people that go to their urologist or go to their primary care physician, and they ask the physician, I've heard about the PSA test, I've heard pros and cons, doctor, should I have the test? And then the doctor is supposed to discuss with the patient what the benefits and the risks are. And then the patient and the doctor make a decision. Mm-hmm, mm-hmm. But the difficulty with this is that not every doctor has discussed the same risks and the same benefits. They don't have a 3x5 card, for example, that they all look at and they all tell the patients the same benefits and the same risks. You follow?
Yes. Maybe you should create that card. I know that.
And then in the 90s, in the late 90s, and I have all this literature, they tried something similar, and it didn't work. And so all this is done, and I'm sorry, I'm giving you maybe a one-sided picture, but what all this has done, this has put PSA screening, back on the map.
Right.
And the data, that is given to support the change in the decision, which we haven't talked about at all, and which is maybe, I don't know how important it is, but there were two large studies that were done. Mm-hmm. The European randomized study of screening and the PLOC, the prostate, lung, colorectal study that were done. And are you familiar with these?
I read a little bit about them in your book, but maybe you can summarize.
Okay. Well, the latest data, of course, is that the ERSPC data claims a 21% reduction. They had two groups, a group that didn't get screened and a group that did get screened.
Right. And
they claim a 21% reduction in prostate cancer in the group that was screened. But two things that are important, and I can send you a recent op-ed, the one that I had in 214, I believe, or 216 in the New York Times, is that two things. One, there was another part of the group, it wasn't one study, there were 7 studies that were done in 7 countries, and they correlated the data. And then there was another study that was done in Gothenburg, Sweden, which was independent, in which there was a 60% reduction in prostate cancer in the screen group.
Okay.
So what the ERSPC people did was they took the data from the Gothenburg study and they put it into their study, which is absolutely, totally unethical.
Right. It wasn't part of their study.
Which made their study, which gave them their 21% significance. The other thing that they did, I'm sorry, maybe I'm forcing this information on you. The other thing they did was they never de-identified the patients in the two groups. And that is, in the non-screen group, when they developed prostate cancer, they were given estrogen therapy. And estrogen therapy is noted to exacerbate or increase mortality in prostate cancer in certain instances. And so the difference of the 21% difference between the two groups may not be 21% difference. It may be because the patients in the non-screen group died more frequently because of the manner in which they were treated.
Wow, that's scandalous.
So I'll send you, I don't remember, I think it was 216, the op-ed in the New York Times. But the thing is, I don't know because we got off on some things, and I guess rightfully so, because you had some questions. But
right.
The thing that was important to me to explain to you that I made it clear was the 5 cruxes, the reasons why PSA screening can't work.
Okay, I don't think we went through them individually. Can you...
Well, okay. One is PSA is not cancer specific.
Okay.
PSA, first of all, PSA is not cancer specific.
Right.
Prostate cancer, there is no level in the PSA test that's diagnostic for prostate cancer. The example being, you can have 0.5 and have cancer.
Right.
And have 0.11 and have 11 and not have cancer.
Okay.
You can't distinguish a local versus aggressive disease.
So you can't distinguish a slow-growing tumor from a fast-growing tumor.
That's right, and it's age-related.
Right, age-related. So older people. Right.
The other thing that's so important is how can there be a debate when I've done some studies with some people a year ago. I spent a couple of weeks I was in Germany. I gave some lectures in Berlin. And I have a paper, but it's in German. Do you read German?
No, I don't read German.
Oh, okay, but let me just tell you, how can you have how can there be a debate when the difference between screening and non-screening, of 1,000 men, is 1 to 1.6 per thousand? In other words, if you're screened, there may be 1 man to 1.6 men that are saved.
Right, but at the same time, a lot more men will suffer the consequences of the treatment. I mean, that's always the problem with screening tests. But Dr. Ablin, I'm afraid we have run out of time. So
okay, I'm sorry.
It's okay. There just isn't enough time. It's a big issue, and I would just encourage people to read some things that you've written, The Great Prostate Hoax, or some of your op-eds. Is there one last point that you'd like to get across before we end?
I think that you should realize when you're making a decision that you really have all the pros and cons of the benefits versus the risk.
I agree. And I think the information is out there, but the financial forces are such that they're not going to make it easy for you to get it. So you've got to find it yourself. And I think you've done a great service in documenting the problems with the use of the PSA test. So I'd like to thank you very much for joining me today. Thank you for listening to episode 201 of The Infectious Myth. If you have a comment, question, or suggestion for a future guest, please email me at david.crow@theinfectiousmyth.com. Like us at facebook.com/theinfectiousmyth. Follow us on Twitter and Instagram at InfectiousMyth. Commit to monthly donations of any amount at patreon.com/infectiousmyth. Until next week, thank you and goodbye.